I'm here. Hi, everyone, and welcome. Thank you for joining us for tonight's virtual workshop hosted by the SPD Junior Faculty and Fellows Committee. Typically, we bring you a quarterly journal club, but tonight is a special edition workshop focused on two important topics. So we have Finding Purpose at Work with Dr. Lisa Arkin and Clinical Efficiency with Dr. Harper Price. A huge thank you to our incredible speakers for giving up their Sunday to share their insights and experiences with us. And of course, thanks to all of you for being here, especially after our unexpected scheduling mishap. It turns out that none of us on the committee are big sports fans, or we might have realized that our original date clashed with the Super Bowl. So we truly appreciate your flexibility. With that, let's get started. So it's my pleasure to introduce Dr. Lisa Arkin, who is Associate Professor and Director of Pediatric Dermatology and Fellowship Director at the University of Wisconsin-Madison. Dr. Arkin is a leader in the field of vascular anomalies, laser therapy, and autoimmune skin disease. And her groundbreaking work has been supported by numerous grants and awards from the Sturge Weber Foundation, from PEDRA, from CARA, and the Dermatology Foundation, furthering precision-based patient-centered treatments. Beyond her clinical and research expertise, Dr. Arkin is a dedicated educator, mentor, and inspiring speaker. Every time I've heard her speak, she brings not only deep knowledge, but also purpose and joy. So with that, I'm very much looking forward to her thoughts on purpose tonight. Over to you, Dr. Arkin.
Thanks, Bella, so much. It's really good to see everyone here. I appreciate all your time. I'm gonna share my slides here. Hopefully it works. Okay. So initially, I had been asked to talk a little bit about mentorship. And for me, mentorship is entwined with purpose, and mentorship in my world relies a lot on research expertise. So I wanted to go upstream a little bit and talk about something a little bit deeply rooted for me, which is purpose, this idea of how to figure out what you love, how to do what you love, how to keep adapting to the things that drive your own curiosity and satisfaction. So, this very short talk, and there's going to be a lot of room for questions, is going to be dedicated to retaining purpose in Peds Derms. So, this is 10 years in for me. Because I graduated from fellowship in 2014. So I'm right at a decade, which probably just makes me middle aged. But also, it's just still the most wonderful field to get to go to work and do what I love every single day. So let's see if this will advance. I don't know what happened with that. Okay. So if any of you are looking for insight into human behavior and the idea of how to figure out what drives people, I'd highly recommend this book by Daniel Pink called Drive: The Surprising Truth About What Motivates Us. This is really a book that tries to unpack this idea that the carrot stick reward, which honestly, a lot of us grow up on just through, high school, college, and then medical school. You take a test, you do a rotation, you get immediate feedback, you go to the next thing. That really doesn't sustain us longitudinally. And Daniel Pink breaks it down. He really breaks down, I mean, it's about drive, and it's about human behavior, but in some ways, to me, it's more about long term satisfaction and happiness. And he unpacks three entities that really are critical to motivating people to achieve their best. And the purpose of the book is to say, like, cash rewards don't really matter. The carrot stick of reward and then the slap on the wrist for punishment, those are not highly effective ways to really motivate people to live their best lives and live their best work. But these three tenets, which are the ideas of mastery, so becoming an expert, autonomy, meaning independence and the ability to do what it is you really love to do or kind of drive the bus yourself, and purpose are the three elements of human behavior that really together are in this triangle that creates motivation and drive. And I would say in academics, um, we don't have a ton of autonomy. I think I'm lucky at UW. We still have some, and I certainly fight every day within our division to make sure that people really get to do what they want and love. But for me, the two areas in this book that kind of motivate my deep satisfaction with the field and my happiness are the ideas of mastery and purpose. And mastery to me is sort of, we became pediatric dermatologists in a way because we like to be dilettantes and do a lot of things, but also we get to be really critical experts within the field in a few things or many things. And certainly we're experts within the field of dermatology for pediatric patients. But for me, mastery was finding two aspects that I deeply, deeply loved, and being able to refine those, unpack those, dig into them, make friends to collaborate, to understand aspects that were critically questioned or in which there were identifiable knowledge and treatment gaps, and figuring out a way within those very small niche areas to close the gap and therefore move the field forward. And then purpose for me, I think everything's sort of rooted in your childhood, right? In some ways, but um, I was a kid who grew up seeing a lot of doctors. I have a diagnosis that is not in any way uncommon in the 2000 plus era. I have EOE that had been misdiagnosed for decades, and so I really had not thought about medicine at all. And for any of you who know my story, I had no interest in becoming a physician. I went to Brown University, I did theater and history, and I moved to New York with a sort of contract with my parents that if I didn't figure out what I was going to do in the first year, I would, go to one of the law schools I'd gotten accepted to. And thank God I didn't do that because I don't think I would have been a happy lawyer. But I really like had this totally random journey. I worked on Broadway as a publicist, then I worked at HBO as a story editor, then I worked at Showtime doing creative development. And when September 11th happened, I was downtown because I had jury duty, and I saw a lot of traumatic, awful things that fueled my purpose in a way that is hard to really encapsulate in a lot of words, but so much as to say, in the months that followed, I made the decision that I felt like I would have more benefit and have more purpose if I could switch careers and go to medical school. And I had been helping children with cystic fibrosis at a big CF center downtown. And a lot of what I did was I worked with some of the actors on Sex and the City. I would call them and they'd come down and play cards with the kids. We took all these dying kids to the Sex and the City premiere. I mean, it was a totally different world where I got to feel like I was helping in a way. And in the aftermath of September 11th, I felt so powerless, in part because everyone was powerless. There were no survivors, but that moment for me was the defining pinnacle where I said, I'm actually going to change what I do with my life. And so for me, every kid that I take care of, every patient I lay hands on is about that sense of, trying not to miss something that was missed when I was a kid, trying to help everyone I can, and in some ways, gaining control back. And I think, you know, it's really important to remember that this idea of purpose, this is not a static phenomenon. It's a totally dynamic. And I think especially when, we go to medical school and then we do residency and we're dermatologists and everyone is, highly type A and motivated. And then we go into academics and we're doing Peds derm and there are all these expectations about how do I get research funding and protect my time, and whatever it is that you see for your life, we have to remember that this really shifts, and that you have to give yourself some grace around that. Your career will adapt, it will flex, it will shift. And that's the beauty of being a physician. Like, and I'm going to show you my failure resume in a minute, but there have been times where I've had no grants. There have been times when I had 4 grants. There have been times when I wrote 4 grants, none of them got funded. Like, all of that is okay. We get to really be flexible because we have this gift of taking care of patients, and that skill, that um, that skill set we have, and the never ending demand for our services will literally never go out of style. And I show this picture because I remember, we had our first child, Benji, in 2014, and I was living in Chicago. We were living in Chicago at the time. And so Albert Yan, who was my fellowship mentor at CHOP, had said, "Oh, you should definitely come to the Pedra meeting. It's in Chicago. It's so close." And I went, I think Benji was like 2 weeks or maybe 3 weeks old. I hadn't slept in literally 3 weeks. There's absolutely no way I should have been at that meeting. And I just remember just feeling completely overwhelmed and awash, surrounded by all these incredible experts, and just thinking like, I can't even see past, tomorrow, let alone what a years long project would look like, or what questions I want to answer in a detailed way. And so, especially for women who are, really in the thick of it, with childbearing and child rearing and all of the like wiping butts and the cognitive, work required to organize everyone's lives, I think just remembering that nothing happens overnight, and it's totally appropriate that things shift and flex. And we did this at the Pedra meeting a couple years ago, and because you guys are fellows and junior faculty now, I'm assuming most people weren't there for that meeting, but it was basically John Harris, who was a resident at Penn when I was a medical student, and I'll never forget Bill James on the first day of residency went around the room and said, "I want you each to tell me what you want to do with your life." And, they got to John, and John was like, "I'm going to cure vitiligo." And what the heck? Like, 15 years later, I guess, yeah, it was 2009. Like 15 years later, he hasn't cured it, but he's come as close as anyone else in the country. So he showed his failure resume, and it was like 15 R1s applied for, fail, fail, fail. And so I'm going to show this in part because I really, really believe in every way that you learn more from the failures than the wins. There's that poster of Michael Jordan. I don't know if you guys have seen it, but it says, "I failed over and over and over again. I succeed because I failed." And I believe that so much, even though when you feel like you're just not hitting it, it can feel so hard. Like you feel so let down. So I'm going to tell you a little bit about my journey, if I can get this to work. Okay. I graduated from fellowship in 2014, got married in May of that year. I'd met my now husband when I was a resident. We went back and forth when I was in Philly and he was in Chicago. I took a job in Chicago because Andrew's family business was in Chicago, and the job was a total disaster. Like I cried every day. It was just a really difficult time. And I think it's good to tell people like the first job you take may not be the last, and that's totally okay. I definitely learned a lot from the experience, in particular about what to ask for the next time. Then Benji was born. He was actually born, in September of that year, so this overlaps a little. And then he didn't sleep for like 18 months. So at the Peter meeting, when I was like, "Oh my God, what is happening?" It was because in part, like I mean, he's the sweetest kid now and he sleeps fine, but he really didn't sleep. Um, then I got recruited to UW, which was actually really hard because I had to move our whole family. I had to take my husband away from his family business. That was hard for a whole variety of reasons. I got my first grant awarded for a room derm project looking at discoid lupus. It was a teeny weeny itsy bitsy polka dot bikini amount of money. Like I want to say, I don't know whether it was 15 or $20,000. It was something, almost like so little because we just wanted to do the project. And of course, then you have like 18 centers and you need 4 no cost extensions because that's just what happens when you have big multi-center trial. Then I came to UW and I realized, I loved room derm, but actually it wasn't really the biggest patient population. And so I was worried that if that was my only focus, I might not have enough patients to understand what the critical questions were. And then I realized there was this huge population of patients with vascular anomalies. And shortly after I was recruited to UW, I had a little girl who'd been denied a referral to UW, had face syndrome, and developed necrotizing strep infection within her segmental infantile hemangioma. And it contracted and scarred, it was necrotic. And so I found this not this niche, but then I didn't have really all the skills I wanted to be able to understand and also to use more tools in my toolbox. And I actually emailed Roxy Anderson, who invented most of the laser technology we use, and he said, sure, just come to spend a week with me at Harvard. And to this day, I have so much gratitude to the whole village of mentors who I lean on still all the time to say, what else would you do? What should I worry about? And that includes Rox and a huge group of laser surgeons who have really supported and leaned in to say, okay, you're a pediatric dermatologist, but you're going to learn to do this and understand all the principles. And I had to really relearn a lot of what I'd been taught, just thinking more about pathophysiology and what the laser does and how to photocoagulate and what the risks and benefits are, and really how to set the laser, how to set the parameters. Then Hudson was born and he also didn't sleep, and he's like a totally different kid, but he literally didn't sleep for 15 months. And after that, he was still up in the middle of the night, probably until like last year, and he's now 6. Then Beth Drolet arrived in 2019 at UW, and I was like, oh, wow, I'm not going to be the only pediatric dermatologist at UW. And she had, a really remarkable vision that integrated research, translational research, the idea of asking important questions. She believed in the field. Then actually we recruited Jackson Turbeville, who came a few years ago, and that gave us 3, and we were able to really significantly expand our services. Before Jackson came, COVID hit, and that was a big, pooperoo. But it leveraged the opportunity actually to join the COVID human genome effort, which was led by Jean-Laurent Casanova. And we had this idea to try to understand what the immune response was to COVID by looking at the skin, and particularly by looking at this phenomenon called pernio. And then after that, I wrote like all these grants, and they all got funded basically at exactly the same time, like an ICTR grant, Wisconsin Partnership. I had a Sturge Weber grant, a Derm Foundation CDA. And then I wrote like R21s. I wrote all kinds of additional grants, which weren't funded, just as many that were funded as weren't funded. And then last year, we started a Peds Derm Fellowship at UW, and our first fellow, who's going to join on our faculty in September, had been a medical student at UW who I'd mentored for years, and literally like within the first week of meeting her, I just knew she was going to do this. And so the fulfillment of like, being able to create a fellowship for her, and she wanted to do something very, very unique. She wanted to do adult inpatient dermatology and complex peds derm. And so we built her this really unique fellowship with, a lot of consultation in the afternoon, including the adult services, lots and lots of procedures, and obviously all the usual stuff as well. And so this is so I don't have any grant funding right now because, grants come and go. And I have a bunch of research projects that are unfunded that I don't feel like I really need money for to do them. But that's sort of my story, and you can see this is a winding road, not with like straight success. There's all kinds of shifts and bumps. And I think the most amazing thing about all of these experiences, even when they didn't feel good, is how much stronger they make you and how much you learn from the experience of failure. So okay, I'm gonna end after this rambling discussion with a couple of pearls on purpose after 10 years. Um, you have to love what you do to make a career out of it. So figure out what pieces you love and lean into those and chase and follow those. Because, plug and play is not a recipe for lifelong satisfaction and happiness. And it's probably why a lot of the data has shown that these translational researchers who have like a single unified niche and do, one thing only, have some clinic, have some research, they seem to have very longitudinal, long lasting career satisfaction. I've said this before, but you will learn more from failing than from succeeding. And that's because failure teaches you resiliency, it teaches you adaptability. It's not just okay to fail, it's actually sometimes better than succeeding. For me personally, collaboration and connection are what I love. They're what keeps me in academics. I love that I can pick up the phone and say, I don't know what this is. Can you help me? And my radiology friend, who may not even be on, will say, what do you think of this? Or the pediatric surgeon who's treated pilonidal disease for 10 years will call and say, I want to do a clinical trial. What do you think of this idea? Will you be involved? Or, a lot of the work we've done bringing laser surgeons and pediatric dermatologists together. Again, everybody sees the world a little bit differently. Like, how can we move the field together? Same thing with the room derm work that I've done. Like, how do you learn from other people who see the world a little bit different? Identify the gaps that are remaining between those viewpoints and then figure out how to close them. For me, I would not be happy doing one thing every day, be it research, clinical care, or education. So it's the diversity that really keeps me happy. And every year I have to say, how am I going to tweak it? Is it too much clinic? Is it not enough? Do I want to write a grant and then change what I'm doing? Like what is gonna work? And again, I think it's really the adaptability and the flexibility that is important, and really being able to do the work for you to say, like, what do I need? And then how do you get it? By going to your leadership and talking to your chair. And then a word on mentorship. So, mentorship for me fuels my sense of purpose. Like our current fellow who I've known since she was a third year medical student, like nothing has made me happier than seeing her grow into an amazing academic pediatric dermatologist. We also have a research fellowship, a 1 year research fellowship, and I've had phenomenal fellows and I've had really difficult fellows where I feel like we're not communicating or they're just doing it to get a derm slot. And so what I would say is like mentor because you love it, not because you have to. This is not a one-way relationship. So you need to pick your mentees wisely. And I think sometimes that's hard. Like actually having the bad relationships has taught me more about how to figure out and invest in the ones who are going to be great. You really want to be transparent. You want to protect your time and choose wisely. And then I think as, pediatric dermatologists, like our time is our most valuable asset. So if it's not working, we need to speak up and be transparent about that too. Outside of medicine, it's really important to make time to do the things that nourish you, in part because they make us better at what we do every day, but it's also important to your family as well and to your life outside. And I sometimes struggle with this when I'm totally overwhelmed and I'm like, I can't figure out how to get out of this rut. But actually, a lot of times just saying, I'm going to take a day off and I'm going to do this, this, and this when I felt stuck actually makes me more efficient and helps to give me greater clarity. There's nothing that is more clearing than just going for a run for me. And then I think for me in particular on the academic side, reading and reviewing other people's work is really important. It helps to fuel the questions you still want to answer. It'll make you a better writer, and it will teach you about research methodology, which I think we don't get a ton of in our 1 year fellowship. And then finally, and this is like my segue to Harper, who's going to talk about clinical efficiency. So prioritizing efficiency will help you maximize your productivity, but also your purpose, because it'll give you time. And time is your greatest superpower, so you absolutely must protect it. So that's all I got. And I know I went over. I'm sorry. I'm sorry. I should not have gone over. But that's what I.
No, that's perfect, Dr. Harkin. Thank you so much for all those amazing pearls. For anyone who is joining us on Zoom, you're welcome to add your own questions in the Q&A for the 5 minutes that we have. To get us started, Dr. Harkin, what is your advice to someone early on in their career who finds who the idea of finding purpose might feel a bit daunting?
Yeah, I think you need to think about what fills you with joy to find purpose. So even if you just think about like the one thing in your day you love to do the most, and then keep a diary, like try to understand day to day, like what things make you happy within the time that you're doing it. Because maybe that gives you a disease state. Maybe that's the idea of getting to, do education and teach the residents, whatever that thing is. It may take you more than like a day to find it, but you want to collect the data a little bit and just think like, what is it among my day that made me feel good?
That's great advice. Thank you. One question that's come in through the Q&A is, how does cost of living and income come into play with purpose?
Yeah, that's a great question. I mean, I think those decisions are so personal, and they're, I can't answer them for everyone. But for me, for example, obviously we're paid more for our clinical work than we are for research. And that was kind of a decision I made a couple of years ago to say, like, I actually really love seeing patients. I don't want to do like, you know, 40/60 or 50/50. And I really am about 50/50 now in terms of clinical days. I also think figuring out how to maximize your efficiency on the days when you're seeing patients so that, for example, you have, I don't know, for me, if I had clinic in the morning, I was never going to write in the afternoon because I was going to close all the charts. So flipping that so I could write in the morning and then see patients in the afternoon. But it's a really important question. And I think each person has to answer it individually and then to figure out what's feasible. There are some institutions where you don't take that much of a cut to have more protected time as long as you've figured out a way to fund that. But I do think sometimes to get that funding, you have to work extra hard because you're not going to get buy down immediately until you've acquired it. I don't know if that answers your question, but I hope it does.
No, absolutely. This I feel like the next two things, if we have time for both, are both questions that could probably be talks in their own right. But how do you say no to things that don't fit with your purpose?
Yeah, that is great. I am extremely bad at that. Thus my like many, many AAD talks that I probably should have said no to. But I think it gets easier. And I think, Dan Bennett is one of my mentors. He's the current AAD secretary. I think he will say to me, "Can you just call me if you're going to say yes to a big thing so I can like tell you no?" I think in you have to do that calculus. Like, is it enough? Is it enough to say I'm going to do a weekly conference call at 7 o'clock at night when my kids are going to bed? Or, is this going to get me something more? I do clinical trials now because they give us drug access for patients who need it. And I like understanding the way industry works and interpreting the data and having a seat at the table when the publications are drafted. Like, whatever it is, you got to do that calculus around purpose, cost, income, like all of that. And it's almost like you sort of need to make a Venn diagram and work all the numbers out before you make any decision.
Absolutely. Amazing. Well, thank you so much, Dr. Harkin. I think we're going to finish off there and we'll switch to clinical efficiency.
Yes, thank you so much. And I am going to introduce Dr. Price. And I realized Bella might not have introduced herself. So Dr. Plumtree is an assistant professor at the University of Massachusetts in Worcester. She's one of our newest members of the Junior Faculty and Fellows Committee. And she really hit the ground running organizing this, which is a different format on a different day. And we're so thankful to everybody. And I'm Christy Garza Mayers. I am at Seattle Children's in Seattle. And I'm introducing Dr. Harper Price. So it's a great segue from Dr. Arkin. Dr. Price is a board certified pediatric dermatologist at Phoenix Children's Hospital. So I think we have every single time zone represented this evening, afternoon, today. She is the division chief and was previously the fellowship program director. And her interests and experience run the gamut from genodermatoses to cutaneous oncology and procedural dermatology in children. And I think I perhaps know her best through PEDRA. She's very active in mentoring early investigators and is really leading the way in pediatric dermatology, navigating relationships with industry to further patient care. So she really seems to be doing it all. It's only fitting that she's here to talk with us today about clinical efficiency. Thank you, Dr. Price.
Thank you, Christy. I appreciate that. Let me share my slides as well. Oop. It always works so well in the practice session, but yet, you know, there we go. That look good to everybody?
Looks great.
Great. And found this new cool little pointer. I'm probably late to the game. But yes, we are switching gears, and Dr. Arkin, that was amazing. Thank you. It's very cerebral and existential, and I'm going to be talking very granular here about clinical efficiency. Work effectively with the little time that you have. And I agree with lots of things that Dr. Arkin said. I am the same. It must be a gene that some of us have in Peds Derm, where we need lots of variety to feel purpose and to be happy at work. And I also wear lots of hats, from education, teaching, to division chief and research. And so I'm kind of pulling on my hat of why I became interested in clinical efficiency, and really found myself, I never thought I would be division chief or have a leadership role, honestly, or an administrative role, because that's a lot of what it is. But I never went into this career thinking that. And how I got here basically was living and working in a work environment that didn't work very well. And I found myself really trying to understand how to operationalize things, how to improve things, because I found that if I just sat there and became more upset about it, and I didn't have a feel at least that I had input or that I could make things better, I was unhappy. And so lots of people say, why do you want to be an administrator? What, there's definitely pluses and minuses to it. But what I've really enjoyed is part of this, making the workplace a better environment for myself and my colleagues to feel like we are more efficient, sometimes as painful as that is. And I realize with all the different clinical environments that you're all in on this call, that a lot of these things you may not be able to do. Sometimes these take time, and sometimes we're in a really complex institutionalized part of medicine where you may not be able to make some of these suggestions, but I think speaking our voice and being heard is really important. So let me move this out of the way here. So I'm going to go through some time sucks is sort of how I've organized this talk. And one of the things, I hope this is the correct one. Let me see one thing here. Well, either way, time suck number one is the EHR. When you look at burnout in national surveys, in MGMA, in Doximity surveys, and AMA surveys, administrative burden is the biggest contributor to what we call burnout, however you describe that. It's also one of the biggest contributors of workforce shortage. It makes people leave medicine. So I've kind of focused on the administrative tasks here that we get stuck with. So starting with the electronic health record, I am not a person who has Epic, and I struggle because of that. And so if I can do non-Epic. You guys can definitely be more efficient than what I'm talking about with Epic, I'm sure. But how do you get through clinic? When you're a junior faculty or right out of fellowship, you've usually been maybe seeing patients yourself in your own continuity clinic or following your attendings around, but it's very different when you are the only one. And so some of the things that I'm going to talk about here are things that we've actually instituted even as I've been a more mid-career and senior clinician, but things now that I think we all have hopefully access to is having scribes. In-person or remote scribes. I remember talking to Rich Antea at a meeting, and he had a scribe that he would get on the computer, open the scribe portal in the Zoom, and they would scribe for him in the room and didn't even need to be in that clinic space. We have in-person scribes now. It is something we've asked for quite a long time. We made a deal with our administration that if we increased our templates, our RVUs, and our number of patients, that we would each get scribes, and it has been life-changing for me. I don't need the extra hours closing charts. I don't have to chart prep as long, and they actually almost function as junior residents. As much as they open the chart, they tell me the background that they've gathered, and I can walk in and feel pretty prepped. But not having that before was a huge time suck for me. The night before, opening charts multiple times, trying to pull source data from different areas. They take notes in the room for us, and then as I'm doing the visit in the room, one of the things that I actually started doing to make myself efficient and to help the scribe is actually to sort of close the visit by summarizing, here's what we've talked about. And they write our end of visit, which we're required to do in our treatment plan based on my last 2 to 3 minutes in the room of going over. I mean, how many times do we go over and over the plan with the family? That's your end of visit. The note should almost be written and almost closed by the time you walk out of the room. And so that's what we've gone from, which is amazing. And again, it takes me just a few minutes at the end of each day to sign those charts and make sure they're correct. Also using things that your EHR may offer you, setting up your favorites for your prescriptions or your coding, so that every time you're not repeating these same things over and over every time you open your prescription writer or we call it Termmeister, your coding. Template common diagnoses in your notes. This may sound silly, like, of course we do, but we say and write the same things all the time. And I thought to myself, why am I having to do this over and over? Those of us that work in academic medicine don't have usually those same EMRs that people have in private practice, which are much more streamlined, much more checkbox. We're required to do a lot more things. So as much as you can template things and make them easy and click boxes is the best. And then acronyms, which I know many of us use in medicine, and handouts, teaching with handouts and being able to put like the SPD handouts into your end of visits easily and quickly can help you get those notes done. This is just an example of what where we put in our diagnosis codes. And you can see here, the minute I start typing, my favorites come up that I've saved before for all the atopic dermatitis codes. And so don't have to search every time and go down big lists. Same thing with prescriptions. I've got my favorites for all the common things I see, and I click on the box and I can go ding, ding, ding. And because I do a lot of the same things each time. These is an example of, and Dr. Arkin might like this with her interest in vasculars, and we have templated some of our very common diagnoses. For instance, propranolol hemangiomas. We're saying the same thing. We're almost always doing the same thing. So we've made some check boxes. When you hit infantile hemangioma at the top of the note, this is kind of what drops down after your plan. If the patient with the hemangioma needs treatment, you hit yes, the indication, what medication you're using. We have various ambulatory and inpatient protocols, and then a nice dosing table. It literally takes 2 seconds. My scribe does it for me now, and I'm sure that I've gotten everything. And this is basically my plan. I really don't have to write very much. I've got a ... phrase for discuss risk and benefits, everything that I say all the time, and I can close this note in 2 seconds. The second time suck that has to do with the EHR is the inbox. And there's 3 parts to this, I believe. You get your notes done and then you open your inbox and you go, oh my gosh, I have 30 messages and here I am. I thought I could go home and spend time with my kids. For us, we get direct patient messages. I know that lots of you do. So I'm starting out with messages from your patients and families. And I found myself when we opened this up 5 or 6 years ago, that I was one of the big users of this, because I would rather message somebody and message somebody back than have to call them. Waiting around for families to get done work and playing phone tag and then having to write notes every time you call them to prove that you called them. This is silly. So I'm a big proponent of the patient portal. But as we all have cases where people abuse that, we get messages every day about every rash. You have to set boundaries. You have to set expectations to your families and patients of when to use it, what it's appropriate for, and then come up with some guidelines of when you're going to answer those messages. One of the feedback some of the feedback I got early on was that you don't answer messages fast enough. We feel like we can't get a hold of you. So I really set an expectation with my staff and all of the providers in our group to say, we will return messages in X amount of hours. We tell that to families too. There's a message that comes back to the family, says, thank you for your message. We've gotten your message. We will reply within this amount of time. If this is urgent or emergent, please do X, Y, and Z, to set those expectations. And also, if your staff are your proxies for your messages, which they should be, you want your support staff to be first line answering your patient-directed messages. You need to make sure that you understand, how often are you checking my messages? How am I going to know that you check them? Train them to redirect your families to the correct, person. We don't schedule, please call this person, please call the pharmacy, these kind of things. Make sure that depending on which staff is answering your messages for you, whether it's medical assistant or nurse, that it's within their scope. And your scope is usually state dependent. My medical assistants cannot give advice. They can only give what I've given to them to say, but they cannot take someone's problem and say, hey, well, you're having, retinoid dermatitis, so, put your triamcinolone on that, because that's what Dr. Price would want you to do. They can't say that. So you have to really know who should be answering what. Also, write in your note if you anticipate issues, and let then your clinical staff go back to that note and follow your instructions. If this fails, my next step would be this, and I would do this. And then you can easily direct your staff, hey, read my note, this was the next step. I found that doing that is really helpful and has saved me a lot of time back and forth, and also from adding people in last minute just to change meds. We all get this, we saw them for atopic dermatitis, but now they have a weird urticarial rash, or a past problem that you actually haven't seen them before, or maybe they haven't been seen in 10 years and now they're reaching back out again. You have to set the precedent with your staff on how to deal with these situations, because it will help the back and forth. It will help not fill your mailbox up. And also give sort of consistency to your family. Hey, you haven't been seen in 3 years. Our office policy is you have to make an appointment now. Rather than saying, oh, I feel bad for this patient, I'll just call it in. Even though I haven't seen them in 5 years. So the other important thing I think I learned really quick early on, especially even in my fellowship, is don't give out your work email or your cell phone email. As much as you want to be there and you might have special patients, it's really never a good thing to do. And we'll talk about boundaries in a minute. The second part of the EHR inbox is messages from your clinicians. Like Dr. Arkin was saying, we phone friends a lot of times. Well, in dermatology, we're often the one being phoned, right? Because everybody in all the other subspecialties and specialties usually needs derm help. So these messages also, you should set the record of, who's answering these, if they're answering them on your behalf, and avoid duplication. A lot of back and forth is what clogs emails. So if you don't need that message, delete it from your inbox, the entire conversation. Think about utilizing flags for more urgent messages. If you go through really quick, but now you have patients waiting, flag those so you don't lose those messages in the queue. If you've got your support staff, messaging with really urgent things, we often say, well, you didn't answer the message, this was really urgent, or you get back to, at the end of your day, you're reading your inbox and all these things that should have been addressed early on when you actually had your support staff there weren't done. because nobody came and got you. So my rule is, hey, if I'm in clinic and something is really urgent, please come get me, because I'm not sitting in clinic in my inbox answering the messages from the nurse about an urgent patient. So it's setting that expectation of what is the response pattern, what is the turnaround time, and how are we going to communicate with each other? Because really most of the communication issues are where people get upset. And what about test results? One thing I realized in fellowship is I called back every test result known to man. Really should not be something as junior attendings that you guys are doing. You learn how to do it in residency. You don't need to keep doing it. With medical assistants, they can often call back normal, negative, or benign results. Make sure they document that in the system so that you've proven that they've done it, and set expectations about when you send them a message, hey, you can release this result, that they know how many times they're going to call, and how to document that. If you have nurses, they can often call back very complex results, counsel patients, and relay changes in management, as long as you've given them those and documented those in a message. And then consider the patient portal to communicate to families. I really love this myself. I find I can head off a lot of things that would be long conversations on the phone. And so something that takes me 2 seconds, and I actually really, really enjoy. Your institutional email. Now you've gotten through at the end of the day, you've signed your charts, you've gone to your EHR inbox, now you have your Outlook or whatever you guys use. And that's 100 messages more, right? And so it just feels completely like we're never going to get home, and you know, the next day it starts all over again. The email inbox has been the vein of my existence, and I sit there and watch it fill up, you know, in between patients. So one thing is, you know, commit on checking it once or twice a day, and that's it. Don't keep checking. You will go crazy. Make sure that, at least in Outlook for me, there's a focus mailbox and an other. I put everything into other that I don't need to read that day. If it's an email about generator testing or physicians on suspension or something goofy, I really work on my focus box twice a day. I block the junk immediately, and I utilize flags. You know, something's urgent, something's due. And then a shared calendar, I cannot, you know, shared responsibility of a calendar. If any of you are able to share any kind of administrative assistant, this to me is so key, to have someone doing calendar management. And we just heard how busy Dr. Arkin is, and I can only imagine your calendar. You know, anytime anybody suggests things, please send me a calendar invite. Please put it on my calendar. My admin assistant does my doodle polls. She deals with every meeting request. She puts ticklers on my calendar. I personally put due dates on my calendar that are helpful. Calendars can really be a really important way to stay clinically efficient and to use your time wisely. And then I just wanted to show, you guys probably know that this focused another box here. I don't need to read AAD every day. I mean, I can chunk through that, but I put that in other. This is my calendar every week. This is, but I wanted to show you how I chunk my time. So you can see here, division chief meetings, research. This one's a great example. My research block time here. So when I have meetings, my administrative assistant for our group knows that if it's a research meeting, it goes on research time. If it's a fellowship meeting, it goes on my fellowship time. You know, if it's a division chief or leadership meeting, it goes here. And that way my patient time is protected, my time is protected, and it doesn't interrupt patient care, and I can really chunk those tasks. And then I know when everybody is in clinic, who's on call, where my staff is. It's important when I'm trying to reach out to various people. So I really, really like what's happened with the calendar. And then flags. You guys all know this, but I think I can't emphasize it enough. The time suck number 4 is prior authorizations. I don't know if anybody feels this way, but this year has been awful for us in Arizona. Everything is denied. It is like insane, 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 insane. We had something magical happen in our division last year as we actually got an in-office pharmacy liaison. It was the hospital's goal to try to have patients get their medications quicker. And so we got the option of having a pharmacy liaison sit in our clinic and help us get medications approved. It's been life-changing. You know, not everybody has that. And it's certainly, I don't know what I did without her now. The fact that, she can do a lot with the headaches, and it's saved my nurses and my medical assistants so much time, hours and hours every week, to that they can go back to clinical care. We've started a shared folder within our group of letters of medical necessity and documents. So you can open up by medication or disease state, and you can pull what someone else has written. You don't have to reinvent the wheel. I should have added ChatGPT, because that guy can write some really good letters of medical necessity as well. And then learning to document in your clinical notes towards the requirements that you might need for a specific medication really helps. What medications have they tried? What side effects did they have? Why did they fail it? Because a lot of times that's what the insurance companies are wanting. So just ways to streamline, so when your staff needs this information, they can pull it, and you can share resources. And again, not do the same things over and over again. And setting boundaries, I think, for clinical efficiency is super, super important. You need your time outside of work. Lisa was just talking about this. You've got to set boundaries. You know, am I going to take texts outside of work about work? When I'm off, am I off? Am I going to take emails outside of work about work? Will I check my emails over the weekends when I'm on vacation or CME? What about when my friends, you know, my colleagues text me about a case and I'm actually on vacation? What do I say? And then curbsides and consults via text. We are always, always open. And I don't know about you guys, but I've got email, I've got secure health messages, I've got my phone, and then we have an institutional Teams, you know, that we text each other with, and Vocera, which is a texting app. So someone can get a hold of me 5 different ways. You have to set boundaries. You have to do it. When you consider setting boundaries, think about these things. What bothers me the most? Is it because people are just sending me photos without any information? Is it because I tend to get these after work and not during the day because I don't want them at all? Address what bothers you the most. Start small. You can also re-educate people that tend to cross what you feel like are your boundaries, or redirect them. Thanks for reaching out, but I'm on vacation right now. Please call my office. Thanks for reaching out. I'm out of the country right now. You don't have to answer. And how will you communicate to chronic offenders? We all have people that are always, always trying to get our expertise and ask for things outside of business hours, or even during business hours when it's not their turn. And then I love these focus modes on the iPhone, the do not disturb, the sleeping, the driving, because I can actually tell if I text somebody that they're busy and they're not going to get to me right now. So we have every right to do the same thing, as our time is just as precious. Clinical efficiency, just a few more slides. How about refills and prescriptions? You get asked 1,000 times, can I refill that triamcinolone? Patient has been seen in 6 months. Can I refill their fluocinolone? Have a refill policy for your office or your staff. If you work in a hospital, it's actually usually a requirement. You can set it so the staff can give whatever refills you're comfortable with, as long as it meets your practice policy. Document again in your note what expectations are. If this doesn't work, we'll go to this. If patient can't get off the topical steroid, we'll turn a prescription for tacrolimus. And make sure that your patients and families are aware of your refill policy. I say you have to see me once a year to get these refills. And I know you have pretty mild to moderate eczema and you only need to come once a year, but I cannot fill it if you do not make your appointment. And so that you don't have that angry parent on the other end that hasn't been seen in over a year and is blowing up the office wanting a refill. How to move along in clinic. So I think as a junior attending and junior faculty, one of the hardest things is, okay, now you've told me how I got to manage all these boxes, I got to do the EHR, and now I've got trainees with me and I've got to teach the fellow, or I've got to teach the residents, or I've got a student with me today. One of my big take homes is kind of teaching in the moment. And, you know, I trained in a particular, you know, environment was very, very, I would say sort of typical of those days of medicine where we would pimp each other and ask questions and put each other on the spot in the room. And that's so not much in favor now, but having a trainee listen and observe you in a room deal with a difficult patient or giving a difficult diagnosis is just as much of a learning experience, and then you coming out and asking them multiple questions. Sometimes I'll come out of the room and say, what did I do well there and what I didn't do well? Because I want them to know that I'm making sure that they're watching me and listening to this interaction and getting something out of those visits. We utilize our nurses for tons of education, especially if I'm running behind. I do my counseling on Accutane or isotretinoin or propranolol, and then nurses come in and they round me out, get me out of the room, and they reiterate all the education again. Your MAs can do that too. A lot of times they can check out, they can rescue you. If you're going into a room where you have a really high maintenance family, hey, knock on the door in 10 minutes. I need to get out of here and move to the next room. So you got to kind of plan your day that way, but your staff should be working. They should never be sitting. They should be helping you get through the day and helping that family have the best experience. When you're interviewing staff for new hires, try to be a part of that so that you can communicate the culture and have a say in who's working in your office. And then be proactive in your clinical policies and procedures if you can be, because they're ultimately going to affect you and your colleagues. So how did we get more efficient? In my clinic, we went to a system called open booking where patients can book themselves and referring providers can book directly on our templates. This prevented a lot of hassle and wrong scheduling by our scheduling team. We use a lot of friendly names, and we can actually identify patients if they get into a new molluscum slot, for instance, that we will automatically prior auth the J codes and the CPT codes needed for potential treatments. So we can go ahead and give the treatments those days. We've identified slots for emergency room and urgent care follow-ups and hospital follow-ups, so they can be booked in there immediately, and I'm not squeezing them into my schedule. And we also have slots for urgent diagnoses like infantile hemangiomas that are maybe ulcerated, difficult rashes in transplant patients, things like that, that then can be flipped into a regular clinic slot if they're not booked. And then we maximized our templates. So really understanding how many new patients and how many follow-ups do you need to see as a practice? How much time do you really need to see patients? You'll figure this out after a few years. Looking at your no-show rate and unfilled rates, how busy am I? How can I maximize my time? Putting in kind of, we call them gray slots or blank slots that you can actually, nobody can see but you, so you can book some of your urgent patients there. And it's not a one size fits all. So what works for Dr. Arkin and her schedule is not exactly going to be what's going to work for me. And then find out if you have a clinical productivity expectation, because you can build your templates around that as well. And so you can see here, this is July, so this wasn't a great example, but we've got this other clinical time built into the template where I can actually make appointments longer or make a quick 15-minute follow-up or put a quick wart injection there, something that I can use to my own, have the autonomy to book into my own schedule that way. And these are just some of the data that you can get from your team, from your leadership team in your office, looking at your no-shows, how many referrals come in per month, how many patients are waiting, or are we meeting the need of our clinic, things like that. So really ask for the data, learn how to use the data. It will make you a much better negotiator and give you a lot more autonomy when you need to go ask for things. So this is kind of our open booking scheduling appointment. And then I said this in the last minute or two, administrative burden is the highest thing for all of us in every single survey that leads to burnout. So the more that we can decrease this, the better it is. That's that. Stop sharing.
Thank you so much, Dr. Price. There was so much packed in there. It was all
I know, I'm sorry.
super
I
helpful.
went way longer.
No, that was wonderful. There's one question. I actually had a list of questions just to kind of get things going. And we only have 2 minutes left, but that's perfect because I think you hit all of the questions. And I feel like this would be the perfect thing for a team to watch together and kind of check each other on what you are doing individually to maximize and what everyone is doing at a higher level. So that was so helpful. Thank you. The one question we have is someone asking, how do you handle and set timeline boundaries with the 21st Century Cures Act and patients seeing concerning positive results sooner than you have a chance to address?
That's that's a really good one. I don't have a good answer for that yet. We tried to push back on that a little bit for certain things. You know, we're in clinic all day. You cannot be in your inbox manning results and trying to head off things. I teach my families patience. If you have good patient, patient provider, family provider relationships, I think is always going to make that better and easier. And setting expectations for yourself. You're going to get this test result. I may not be able to call you back right away. Those kind of things. I think that's where the question's going. This is all that burden, right? Like, what can we do? It's a great question. If anybody has any other ways they've gotten around that or sort of helped that situation, I'd love to know. I think I could honestly do a 2-part series on this, because there's so many things that we don't share with each other that could make us all more efficient and our lives better. But yeah, it's a tough problem.
I was just gonna add, Harper, at UW, like if DermPath's gonna read it and it's bad, they call you directly, or
yes,
they you before they release it, which is a nice thing to be like, okay, can you hold it until tomorrow? I'm gonna call the patient tonight. I mean, we can't always do it with SurgePath, but like for
yes, right. If it goes to DermPath, yep.
yeah, that's a nice.
That's a great point. And radiology too will often call us. I mean, it's rare, right? Thank goodness in derm that we get something bad, but they'll actually call us in the middle of a scan if they're really concerned about something. But when this first came out, we we didn't have those types of things set in place. So yeah, great point, Lisa. Thank you.
Well, thank you both. We are just now at the hour. Thank you for all the tips. And I wanted to say also thank you for the shout out for the patient handouts from the SPD. Those are super helpful. I love the idea of us leaning on each other. So again, thank you for being here. Thanks everyone for tuning in. And I guess people will see each other at the AAD.
Sounds good. Thank you both. Thank you, Bella. Thank you, Christy.